share our practice in the atrial fibrillation. My topic is atrial fibrillation ablation in the Fluoroless EP lab, which is maybe the most changes in recent years in our center. We all know that atrial fibrillation is the most common tachyarrhythmic in clinical practice. With the advancement in the understanding of the atrial mechanism and the tools and a large number of clinical studies, just like Dr. Sen shared us, we know that the catheter ablation is an effective method to treat atrial fibrillation. So the level of recommendation of atrial ablation is increasing very rapidly in recent guidelines. In terms of the incidence of atrial fibrillation, the number of the atrial fibrillation patients is growing very rapidly with the aging of the population. Nowadays, in China, we have about 20 million patients have the atrial fibrillation, and every year there may be about 0.7 million patients will newly develop the atrial fibrillation. So the volume of the atrial fibrillation procedure is very huge in China, in Chinese hospital. Compared to the large Chinese population, the number of the hospital is very limited. So the left figure shows the number of inpatients and outpatients in our hospital. There are over 16,000 inpatients in the last year and over 225,000 outpatients in the last year. And the right figure shows the annual volume of the EP procedures in our center. Last year, we performed about 3,000 EP procedures. So the work is really very tough for Chinese EP physiologists. 2 years later, before we conducted a national survey-based study to assess the occupational health hazards in interventional cardiologists in China, compared to the group of non-interventional cardiologists, we found that interventional cardiology in China experienced significantly higher incidence of the body pain, mainly the back, due to the long time of work and the long time of wearing of the lead personal protective equipment. Fortunately, the advancement of the ablation tools have developed a lot in this year. For example, in the very early years, we using the point-by-point technology to build the geometry, and nowadays we have the high density mapping and and we also have the ultrasound technologies to build the 3D mapping, 3D geometry, and other technologies include the contact force sensing catheters and intracardiac echocardiology technologies. The eyes helps to display the intracardiac structures and can assess the cardiac functions, visualize the catheter positions, and monitor some complications such as pericardial effusions. Based on the technologies development, nowadays zero fluoro atrial ablation now is totally available in experienced centers. So we tried to start the zero fluoro EP technologies in the DSAs, which is standby DSA equipment standby in the EP labs in 2019, and we begin to perform the EP procedures in the surgical operation theaters since 2020. when scheduling the EP procedures in the operation room, we can see that all the staffs do not need to wear the heavy protective equipment. The whole working state is very relaxed. We think that this situation that when we perform the procedures in the Fluoroless EP lab, we have some potential advantages. Firstly, it can be totally limited the using of X-ray to help us to avoid the radiation, can reduce the harms of the radiation and relieve the occupational damage caused by the long-term use of the protective equipment. And also it can reduce the cost of purchasing and maintenance of the equipment used, such as DSA and other related equipment. And in addition, we can schedule the EP procedures to the surgery rooms, which help us to have more rooms and reducing the scheduling conflicts with the other interventional procedures. This is our equipment in the surgical operation theaters. Relatively special point is that we need to prepare a special operating bed, which is the massage table we selected, which is it has no mantle, so it will not interrupt the magnetic field of the 3D mapping systems. And of course, the patient is very comfort to lie down during the procedure. And the other equipment is the same we used in the traditional EP labs. And this is the workflow of the zero fluoro AFib ablation. Firstly, we insert the ice catheter into the right atrium, find the home view, and we rule out the AOA thrombus, evaluate the pericardial effusion, and then we perform we insert the CS catheter to the right atrium and to get some right atrium matrix, and then we perform the transeptal puncture guided by the ice. And when we complete the transeptal puncture, we use the ultrasound technology to build the 3D AOA body and combined with the pantry catheter. When we have the 3D model of the left atrium and the PVs, we do the PVI with contact force catheters. And during the whole procedures, we use the ice catheter to monitor the complications. This is sorry. Yeah. We choose the right side femoral vein to insert all the catheters to avoid the injury of the veins, because it may have more chance to injure the veins when we use the left side veins. Firstly we insert the ice catheters and to keep an echo-free space at the tip of the transducer. When we find it difficult to insert, we can inject some sealant and follow the bubble flow, and then we will find the home view. This is our special method to do the transeptal puncture. We use the ice-guided electrified GW transeptal puncture. So we can see that the tip of the dilator we put on the puncture position of the H receptor for the ovalis, and we see the tanning sign, and we make the tip of the J-shaped wire emerge very slightly from the sheath, and then we deliver the electrical angulation energy by connecting the J-shaped wire in the vitro. We can see the echogenicity of the FO at the tanning signs, and a large number of the echogenic are observed in the left side, suggesting we get a successful puncture. So then the J-shaped wire is advanced into the left side and the LSPV. We found this special method to get the transeptal puncture helps us to obtain the best puncture point very simply, and is very safe and effective. When we successfully performed the transeptal puncture, the rest operation is the same as what we did in the traditional EP labs. We use the 3D geometry built by the ultrasound and the FEM, and when we do the PVI, we always use the eyes to guide the to view where the position of the catheter to make sure the ablation site is very precise. This is when we do the left side PVI, we can see the tip of the catheter is just on the crown of the left superior PV. And we can also use the eyes catheter to help to guide the ablation of some linear ablations, like the mitral isthmus ablations. And it's very, and it's very easier to guide the CTI ablation when we use the eyes to monitor the contact and the position. And some special complication when we maybe operators were worried about is about the cardiac tamponade happened in the surgical room. So fortunately, when we using the eyes monitoring the cardiac effusion, we can observe the effusion at a very early stage, and we can also do the epicardial puncture to relieve the tamponade. Over the last 2 years, we analyzed the data. We did the zero fluoride AFib ablation in the surgical operation theater. From 2021 to 2022, there were 136 patients in total underwent zero fluoride AFib ablation in the surgical operation theaters, and we chose another group for the as the control group. So the baseline of the two groups is mostly the same. Of course, we choose more patients with paroxysmal AFib, which may be a little bit easier to ablate in the Fluoroless EP lab. And we found that there's no significant difference in the details of the procedure. All PVs were successfully isolated, and the procedure time and ablation time were comparable between the two groups, as well as the complications include as cardiac tamponade and hematoma. There's no different. And after about 8 months follow-up, there were about over 10% of patients in the surgery room group, and about 20.5% of patients in the control group had the AFib recurrence. Based on the experience in China about the non-fluoral catheter ablations, we have recently organized a team of experts in China and abroad. We reviewed the research and our experience, and then we write an expert consensus on the constructions of the Fluoroless cardiac EP lab and related technologies. We just held a consensus launch earlier in this month, and the paper will be published recently. Thank you for your listening. That's my presentation.